good morning, everyone. It's my pleasure to welcome you all to the CDE program conducted by the Department of Oral and Maxillofacial Pathology and Oral Microbiology, Vmsdc, in association with the Pierre Fauchard Academy, India section. Pierre Fauchard Academy is an honorary dental service organization founded in 1936 in US. And PF begin this program, I request our HOD, Department of Pathology, and Secretary, PA India section, Dr. Maya Ramesh ma'am, to deliver the welcome address.
Yeah, thank you, Vidya. A very good morning to all. Respected Dean Vmsdc, Professor Dr. J. Babyjohn, Chairman Pierre Fauchard Academy India section, Professor Dr. Rajiv Kumar Chuk, Senate members, fellows, senior faculty, postgraduate students, and interns. I welcome you all for the continuing dental education program conducted by Vinayaka Mission Shankaracharya Dental College, one of the 27 constituent colleges of Vinayaka Mission Research Foundation deemed to be university. We are privileged to have two speakers, the two international speakers. The first speaker is Dr. Anand from SeGi University, Malaysia, and the second speaker is Dr. Sivan Padmapriya from UAE, RAKMHSU University. I welcome you all. Now we can proceed with the video.
Now, I request our Dean, Dr. J. Babyjohn, sir, to deliver the Dean's address.
Thank you. Respected President of Oral and Maxillofacial Pathology and Microbiology, Dr. Professor Srinivas Vanki, my close friend. Respected Chairman of Pierre Fauchard Academy, India section, Professor Dr. Rajiv Kumar Chuk, also my senior colleague in various associations and forums and a mentor. The Secretary of Pierre Fauchard Academy, Professor Dr. Maya Ramesh, my own colleague at the institution. The Senate members of Pierre Fauchard Academy, the office bearers of Oral and Maxillofacial Pathology and Microbiology, the postgrads, the interns, and all the viewers across. A warm greetings to you all on behalf of Vinayaga Mission Shankaracharya Dental College as well as Vinayaga Mission Research Foundation deemed to be university. At this outset, let me thank the oral and maxillofacial pathology and microbiology specialty as well as the Pierre Fauchard Academy integrating together to conduct a national level continuing dental education program in an online manner, and that opportunity for having given to our institution, that is Vinayaga Mission Shankaracharya Dental College. I'll have to thank you on behalf of the institution as well as the management. Having said that, I would like to also welcome our resource person of the day, Professor Dr. Anand S, Associate Professor, Faculty of Dentistry, SeGi University of Malaysia, as well as Dr. Professor Sivan Padmapriya, Associate Professor, RAK College of Dental Science, UAE, for having accepted to be a part of the resource person for this wonderful continuing dental education program. Also to commemorate our Silver Jubilee celebration of our university. We have more than 24 faculties of different specialities spread across 4 different campuses. And more than 170 courses are being conducted. So we are really happy and proud that oral and maxillofacial pathology as well as the Pierre Fauchard Academy has come forward to give us this honor of conducting this CDE at our premises. I'm sure with this resource person's extensive knowledge, this specialty of oral maxillofacial pathology and microbiology, and for the topics which is of more relevant to the present scenario that's happening across the globe, should be beneficial for all the viewers across our country and internationally as well. So once again, let me welcome all of you for this continuing dental education program to have a wonderful session as well as a deliberation with the resource person. Will give you an insight about how important is the specialty of oral pathology and how important is the platform given by Pierre Fauchard Academy for developing our own profession and thereby understanding the basics of what should be known and thereby integrating with the diseases and diagnosis and to give a better treatment plan and a quality of health, which is our fundamental responsibility as a professional, which we always take as an oath. And I'm sure this deliberation will be of immense use to one and all. Thank you so much.
Thank you, sir. Today, we are honored to have with us Dr. Rajiv Kumar Chak, Chairman, PFA India Section. We are privileged to have you among us today, sir, and we thank you for taking your time out of your busy schedule to extend your support. I request Dr. Matthew Jacob, sir, Associate Professor, Department of Oral Pathology, to introduce the chief guest.
Thank you, Dr. Vidya. It is indeed an honor for me to introduce our esteemed chief guest, Dr. Rajiv Kumar, a distinguished specialist in the field of dentistry. With over 4 decades of experience in private practice in Delhi, Dr. Rajiv has made a significant contributions in dentistry, both nationally and internationally. He currently serves as the president of the IDA National Head Office and has been a member of the Dental Council of India since 2015. As an alumnus of King George Medical University, Lucknow, he received an advanced training in microscopic surgical endodontics at the University of Pennsylvania, USA, and has been a member of the American Association of Endodontics since 1993. His leadership roles include serving as the founder Secretary General of the Indian Academy of Restorative Dentistry and the Secretary General of the International College of Dentists, India, Sri Lanka, and the Nepal section. His expertise is widely recognized as reflected in his fellowships with prestigious organizations such as International College of Dentists, National Academy of Medical Sciences, Academy of Dental International, and the Pierre Fauchard Academy, to mention a few. His contributions to dental education and research are unparalleled, and he has been a visiting professor at Sibar Institute of Dental Sciences, Guntur. He is a highly sought-after keynote speaker and has delivered lectures at numerous national conferences and conducted several CD programs. His excellence has been acknowledged through several prestigious orations, including the Dr. M.L. Soni oration, the Professor C.P. Govilla oration, and the Dr. N.K. Agarwal oration, as well as the Colgate MP State oration. With his vast experience, academic contributions, and commitment to advancing dental sciences, Dr. Rajiv continues to be a guiding force in this field. It is indeed a privilege to have him with us today, and please join me in welcoming Dr. Rajiv Kumar to today's program.
Now, I request Dr. Rajiv Kumar Chak sir to deliver the Chief Guest Address.
Please unmute, sir. Sudarshan. Yes, sir. You are unmuted now.
Good morning, Dr. Baby John. Good morning, the other faculty members and the honored speakers of today's program. My dear students, my dear fellows, Senate members of PFA, and on behalf of Pere Forscher Academy India section, it's my privilege to be a part of this scientific deliberation. I have, okay. Pere Forscher Academy is really delighted that in this scientific program, we are a partner, though all the effort is being made by the Vinayak Mission Dental College. But we are really honored and delighted that we are a part of the scientific endeavor. You know, Pere Forscher Academy has always been associated for its scientific content. We try to conduct as many scientific programs as possible. So this is a great opportunity for us to collaborate with the Vinayak Mission Shankaracharya Dental College and be part of this scientific activity. You know, Pere Forscher Academy is a global organization which has been existing since 1936 and is in 147 countries, and it has 55 regions in US and 11 global regions. And the India section, which was started in 1976, eventually was registered in 1986. And is growing in strength in these last 39 years. We have about 1,200 fellows in India. Our selection process is very, very strict, and we only induct fellows who are worthy of this fellowship and are introduced by some fellow. Only then they can be inducted. It's only by invitation. So you can't just apply and get a fellowship unless it is recommended by some fellows. But if you are worthy of this honor, we will definitely make sure that we include you in the Pere Forscher Academy as a fellow, because we need worthy people, learned people, and people who can contribute to the profession scientifically and on community events. We conduct a lot of activities. Our main force is our scientific journal, which has been there ever since we started in 1986. And we also try to encourage the young talent. We give awards to the students. We kind of encourage them by international and national awards both. And this is one reason that students look forward to this award, because this is a sought after kind of an award. And we are, in fact, looking forward to continue our association with the Vinayak Mission Shankaracharya Dental College. And we are planning to hold our mid-year convention at your dental college in Salem in August. We have all, I think the dates are almost finalized. and we'll be sharing it with all our fellows when the dates are announced. And if you can physically join us, it will be a great pleasure. Otherwise, we will, of course, make it a hybrid also. So thank you, Dr. Baby John, for involving the Perifascial Academy in this on your 25th anniversary celebration. And I thank the speakers for contributing, Dr. Sivan Padmapriya, Dr. Anand, and I thank the faculty members of the Dental College. I thank my fellow colleagues, and we look forward to continue this association and grow together. Thank you so much.
Thank you, sir. Now I would like to request Dr. Diana Prem ma'am, Associate Professor, to introduce the first guest speaker for the day.
Thank you, Dr. Vidyavarshini. A warm morning greetings. A warm morning greetings to one and all present here on the floor. Myself, Dr. Diana Prem, Associate Professor from the Department of Oral and Maxillofacial Pathology, feel delighted to introduce the first speaker of the day, Dr. Anand S. Tegginamani, an alumnus of PMNM Dental College, Karnataka. Sir is the first oral pathologist to receive a PhD from Rajiv Gandhi University of Health Sciences, Bangalore, and he is the fourth oral pathologist in India to receive a PhD from a government university. In the year 2014, in the same year, the IAOMP, the Indian Association of Oral and Maxillofacial Pathology, awarded him a fellowship, and Sir is the fellow of the association. He is a recognized academic supervisor at Rajiv Gandhi University of Health Sciences at over 2 decades, having a postgraduate and undergraduate teaching experience in oral anatomy, histology, oral biology, oral pathology, and cardiology. He has authored various books on oral pathology and also has been a contributor to the pediatric dentistry textbook, McDonald and Avery Dentistry for the Child and Adolescents. He has over 60 research papers published in indexed journals throughout his careers. Since 2018, he has been a resource person at the IAOMP national conferences and postgraduate conventions and has presented over a dozen webinars for dental college across India. He has also served as a joint secretary and vice president in the Indian Association of Oral and Maxillofacial Pathology and has been the executive editor for the Journal of Oral and Maxillofacial Pathology. Currently, Sir is serving as an associate professor at Malaysia, SeGi University since 2015. We are proud to have you amidst us, Sir, to share your knowledge on the newer concepts on oral leukoplakia. The floor is yours, sir. A small note to the participants. Kindly drop your questions or your doubts in the chat box during the session so that it can be discussed later. Thank you.
Very good morning. Hope I'll keep up to the expectations what Prof. Maya has thought. We'll have a small game before we start.
Sudarshan, kindly unmute, sir.
Okay. Before we start, we'll just have a take a 10 minutes. Can please do login for the Kahoot? Then we'll start. Okay. Hope you all can see the screen.
Yes.
We have around 19 questions. This I have prepared for the interns and for the undergraduates who have logged in. So the first preference, please, the undergraduates and the interns can log in and the postgraduates. Very simple one. And anybody non-oral pathologist sitting, don't be something like I will be talking something about the histopathology and making you poor. Don't worry. My 20 minutes talk will be of interesting and it will not be about the only with the histopathology. I have not added a single slide of histopathology. So don't worry. Let us enjoy. Yeah, another 20 can add up. Okay, I think we'll start with that. Any more can add up with that. I think we are running out of time. Okay, best wishes for all the undergraduates. Leukoplakia means a white patch. True, false. Okay, so we have right answers for the 27. Next one. Oral leukoplakia is an histological term. Nice. Okay, this I had taken from the journal. It was quite interesting. Last year, they made an online, the same question was there. So I just took it from there. Which of the following condition on the oral mucosa is already oral cancer in more than 50% of the cases? Okay, 21 were right. Oh, Dr. Namita is leading. Third consecutive. Oral leukoplakia is a precancerous lesion, condition, disorder, disease. Exactly. This is the reason I just wanted to know before I start with the session. Okay, still Dr. Namita leading up. Very nice. Dr. Madhubala, pick up. Okay, this is quite interesting. I am interested to know about this. A 25-year-old male reported with a white patch and he had a history of smoking for 5 years. Do you expect him to get a malignant transformation? Yes, because he had a history. Okay, welcome for this. Please go. Namita is still leading. Okay, Madhubala, back up. Okay, now, same patient. Only the history is changed. The 25-year-old female, no history of smoking. Does she still high risk for the malignant transformation? True. Even though she is not a smoker, females are more chances of getting malignant transformation even without the history. That's this is what I wanted to know. Okay. Ah, thank God. They're like now somebody has backed up. Sam, very good, Sam. Very nice. Okay. Which of the following? The following disorders are being called as OPMDs. All are correct. Okay, Dr. Hema, good. Madhubala getting to the next level. Okay, predicting factors for the malignant transformations of the oral leukoplakia. Okay, very interesting. All is correct. Okay, okay, Dr. Hema still leading. Kirti, back up. The non-homogeneous leukoplakias have more potential for malignant transformation than the homogeneous. True, false? Yes, it's true. Okay, Dr. Hema still leading. This is the contrast. This is a little interesting. Just go through. In India, the buccal mucosa is the most common subsite for the risk of oral mucosa. True, false? Yes, true. Okay, congratulations. Me has suddenly shown up to the first. Kirti, buck up. Okay, in the Western world, this is the differences why we find global differences. It's not the true in the rest of the part of the world. The buccal mucosa is not the one which will transfer for the oral malignant transformation. In the Western world, the most common oral subsite at risk is very good tongue and the floor of the mouth. Okay, Dr. Namira, Ritesh, Bakab. Okay. Histologically, non-dysplastic lesions have no potential for malignant transformation. Last two more. Huh? Yes. True, false. It's no, huh? Actually, it is other way. It is welcome. We'll see in the discussion. Answer is wrong. All oral leukopenia will become into squamous cell carcinoma. Answer is false. All will not become. Hello, welcome on the board. Sam, oral leukopenia may occur any part of the oral cavity. True. Okay, Dr. Amira and me, Sam. Okay, last one more, I believe. Okay, this is quite interesting. Just go through again. A 35-year-old male with an white lesion on the dorsum of the tongue. What is your diagnosis? Very interesting. 20 said all are correct. Exactly. This is a where the concern is. All white lesions are of maybe of a different spectrum of etiology, but still we consider it as an white lesion. We just cannot call it as a leukoplakia. We'll discuss in that. Okay. Now, a 35-year-old bilateral, what is your most probable diagnosis? This is our OBA question. This we put it as one best answer. Out of all four are correct. One best is you have to pick up. Microplanus is correct because the bilateral, even bilateral, we can have a leukoplakia, but the less like appearances bilateral was more towards of a lichen planus. Okay. All leukoplakia need to be biopsy. Last one more. Yes, it needs to be biopsied. Why we'll discuss. Okay, Ritesh, back up. Last question. All the leukoplakia require treatment. True. It requires a treatment. Okay, that is for the 19 of 19. This is the last one. Which of the surgical options are good for the patient, not for us, good for patient? Okay, the best is considered to be in the C, we'll discuss, we'll come for that. Okay. Okay. That is the end of the session. And thank you very much. That was very interesting. And thank you for all the participants who did. This is what we do it for the tutorial after the lecture class. How much a child has understood. Okay, Dr. Hema, congratulations. Okay, let us skip and let's start with the presentation. Okay, hope you all can see the screen. Hello?
Yes, sir.
Okay, we'll start. Okay,
Yes,
we'll start with
sir.
that. Thank you very much. We'll continue with the presentation. Okay. Okay, this is my workplace, SeGi University, Kota Damansara, Malaysia. And a small video clip we have about the university. You know, thank you. Okay. Today's presentation is for all the undergraduates who are our budding graduates, postgraduates. Okay. I'll not be talking about them. I think more beautifully the oral leukoplakia, Prof. Maya would have already taught you, and her colleagues would have already taught you. Know more of that. We will not discuss anything. I've just tried to make it something which is a need for your clinical work and also need to know. I tried to get only the 24 and 25 article so that I know now everything is available in the internet, so no need to bother much. But what I'm trying to do is try to help you out how it can be made easier for you, and do write in exams, do write whatever Prof. Maya has taught. Don't write all controversies what I am mentioning here. Okay. Okay. This is self-explanatory, Arjuna and Eklavya. this is those who have been seeing my webinars and my presentations at the conference, these first 4 slides are fixed. Okay, there onwards I change. Now, interesting part is everybody have one, even Arjuna had one teacher. I had more opportunity. I was very opportunist to have 4 teachers. This was my first teacher of oral pathology who started with an oral pathology, oral biology. He's a dean in Bagalkot, my alumni institute. And also he's a president for this year. Thank you very much, sir. This is professor and head at the Nair Institute of Bombay. He is my postgraduate teacher. I'm very happy to say that I was his first postgraduate teacher, student. Okay. And this is Dr. Rekha, and she is my PhD guide. She is from the Kidwai Institute of Oncology. She is my PhD supervisor. And the last one is, I don't think we need to say any word. He is a genius, world-renowned oral pathologist. He did not teach me oral pathology. He taught me how to be in the oral pathology. So I consider him as my Dronacharya, and I've been Eklavya as Gurukul. Although they are more 4 teachers, I had 4 Dronacharyas. I did not become Arjuna. That is second. Let us not concentrate on that. Okay. Okay. Anybody? Who's this? Okay. This is the one the bell which rings very often now. The Alexander Graham Bell in 1876 invented a telephone. Now, how is he related to oral pathology? Don't worry. I'll come for that. Okay. Anybody by chance know who is this? Yeah, he is a dermatologist, Hungarian dermatologist. In 1877, introduced the first time the word Leukoplakia. Okay, so something related to Graham Bell and the Hungarian anything? Yes. Okay, we'll come for that. Okay. Anybody who doesn't know him? Everybody knows. Okay. So the advancement has taken from the telephone from this to this. The phone has become from this to this. For the Leukoplakia also we have advanced. We have taken a lot of steps and we have been advanced, and we have around 5 to 6 definitions, and every year we get within new definitions for that. Okay, we are very good at it. Okay, we are defining, redefining. First, we called it as precancerous. Then we named it as potentially malignant disorder of the oral mucosa. Then again, the same PMDO become OPMD. Okay, then the recent 2018, there is a new terminology has been proposed, PPOEL. Okay, and those who are exam going students, 2025, stay tuned, something else might come. Okay, sometimes I feel even the Leukoplakia must be thinking, okay, these are the new definitions you all know, so I'll not read on that. This is on the 2022 WHO new definitions for the OPMD, Leukoplakia, and OED. Okay. Means now oral leukoplakia means just a white patch. Now the problem occurs is this is also white, this is also white, this is also white, this is also white. Means keratosis is also white. The toothpaste reactions happening with this also is a white. Even a glass blower will also get a white lesions. So should we consider all this as a leukoplakia? Is that okay to call them as a leukoplakia, or is this of concern for us? These are of lesser concern for us. Even if you call it as a leukoplakia, don't call it, doesn't make, but we need to call them by their name is better, I feel. Just because they appear as a white, they are not leukoplakia. We cannot call it as a leukoplakia. We have something else in our mind to call it as, because it looked like a jackfruit. This also looks like a jackfruit. The third one also looked like a jackfruit. No. They appear similar, but they may not. Okay, This is the second one is a durian, and the third one is a breadfruit. Appears something like a jackfruit like, and they are quite expensive. This and tastes also differ, and the smells also differ for that. So just appearance or they look like that, it doesn't make any differences. What's in the name? No, there is a lot in the name. Okay, this is a clinical term. In the Kahoot, the half of the percentage said histological term. Okay. Now the problem occurs is these also appear as a white. But these are of more concern for us. These are of more concern. These OPMDs are of more concern because they may not be of a good in the course down the lane. So diagnosing is challenging sometimes. That may be because of the wide spectrum of the diseases with different etiology and the prognosis. The OPMD is interestingly those with the it has a potentially malignant. It's not a precancer, nor it is a cancerous. It's a potential malignant, and even it is not a lesion. It is a disorder. So that's the reason it's called as OPMD, oral potential malignant disorder. Okay. Now there are lots of types. This the right side one was very commonly used when I was just graduated. Type 1, type 2, type 3, type 4. Now we I think more of the people we like to use this one on the left side, which is homogeneous and non-homogeneous. In that, A, B, C, D, E, F are there, and for the non-homogeneous also E, F, G, H, I, J, K is there. So we'll take into two fixed ones, the homogeneous and non-homogeneous. So the air they consider non-homogeneous are more potential for a malignant transformation than the homogeneous one. So I was just saying the postgraduate be ready. So this is I saw in the article in JIDA. This is an Irish Dental Association. They had published something called as ebbing type of oral leukoplakia. I don't know. We can just what is ebbing means. Ebbing is something called as wave-like appearances. They are good at English, so we can consider for that, or we can just put it as wrinkle type in the homogeneous wrinkle type. We can just call it as maybe this may be your viva versa question for the postgraduate. What is the other type is called as? This is something we can consider for the ebbing type, but it's a part of our wrinkle. I think we will put it as a wrinkled one. Okay. Now, what is etiology? Etiology basically is unclear. How exactly it happens is not known. Maybe as with the other cancerous lesions, it can also be because of the tobacco, any form of the tobacco, smoke, without smoke, then with alcohol. These are the main drivers of the oral epithelial dysplasias. And the one which is very interesting is like it's when it becomes a combination. Most of the people when have they have a liquor, then also they smoke also. That's more dangerous when but alone the alcohol causing the oral leukoplakia, it's not been supported. They put it as it becomes a increased risk when there's a combination with the liquor. You can see the left side map. This is the reason why we tend to get more of the oral leukoplakia in Southeast Asia than with the not with the other part of the world. The prevalence is not much higher in the other part of the world. This part, where they have marked it in the red, is the mostly used for the aracanid, and that may be with the tobacco and also with the all sorts of tobaccos without smoke. So maybe potentially it may be a genetic predisposable, or it may be chewing habits or other social habits. And unfortunately, oral leukoplakia can also be seen with the non-alcohol or non-tobacco users also. Now, sometimes what is this lichenoid reactions may be seen with the patient with a long-term drug medications happening for that. So knowing the past history is very important. Okay, so ask for the past history. Know his past history. Taking the history is also very important. Okay, these are the fifth edition's summary. So these are leukoplakia is the most common OPMD, and the global prevalence is less than 4, and that's the reason I said that it varies with each study, and more common with the Southeast Asian. Oral leukoplakia is more common with the men than with the females, but when it occurs with the females, the chances of becoming malignant transformation is higher. Advancing age is also considered to be a risk factor for the malignant transformations, and tobacco, any form with or without smoke, and in the W book says it is a lesser degree of alcohol abuse. I mean, the combination of two can increase the chances of that. Okay, now this is interesting. Why? Now a patient has come to you. What next? If something like this, a patient has come to you, obviously you will going to take with the biopsy. This is also there was a question in the count. All the needs to be a biopsy. Yes, this is obvious because it is a big is bad. So you have taken a biopsy for that. Now, what about this? Do I need? Yes. Whatever the size lesions, to take the biopsy. That has been advised to be advisable for the benefit of a patient and also for the safer side of a dentist. Also, you need to take a biopsy. It's more advisable. Okay, so all the cases needs biopsy. Yes, it does needs. Although we know that all of them may not go for the progress for the carcinoma. That was the right answer. Most of you gave the right answer that it doesn't progress for the cancer. Okay, but if you remember the Benjamin Franklin's statement, if 100 guilty escape is okay, but one innocent should not be punished. The same way, you never know what lesions, what is a big or a small. Definitely big is bad, so definitely you are going to take with the biopsy. Even the small one also, you need to go with the biopsy, because we do not know which of this white patch will transfer into malignant transformation and which does. We do not have anything factor seeing or anything that I can do it and I can say that, okay, this is the one is going to go for the malignant transformation and this patient will not go, other than the factors also. Okay, so any patient can have a transformation and transfer into it has a potential. It can become a show, its real show like this. Okay, so do take a biopsy, get it evaluated. Okay, now when it's interesting, if you cannot take it at one tattoo, please, those who are non-oral pathologists, those who are seeing the, we have a small request for you all. When you do it, you can take something like this, 1, 2, 3, 4. If you want, if it's not able to make it in a one chunk, then when you do that, please to see through that, you put it in 4 different bottle and you can name it as 1, 2, 3, 4, or you can please do it as A, B, C, D, however you convenient. And do send all the 4 tissues to the same oral pathologist, please. Okay. Now you're sent for the histopathology. The problem with us will start from here. Okay. The grading of this is a subjective one. Something like Prof. Maya, it might appear as a mild. For I call it as a moderate. Okay, there is still discussions with this. So this is a subjective matter of histopathologically how they appear for. Okay. Now we grade it into 3, the mild, moderate, and as a severe one. No more we use it. Those who have graduated before 2022 would have read this carcinoma in situ, means from the basement membrane to the top of the epithelium, all the cells are involved. The darker cells here, if they are at the 1/3, we call it as mild. If it's a 2/3, we call it in the middle third, we call it as a moderate, and it is from the bottom to the top is a severe. No more usage of the term carcinoma in situ. Now it is in the undergraduate, postgraduate, it's always been thought something saying that this is the severe, the malignant transformation depends upon the grading. Means severe is more chances, that we all have understood that. Okay, now the challenge occurs here. Now, as it has been severe, so chances of becoming into the cases reported are 30% patient reported with the malignant transformation. That makes sense. That is because severe is going to become into a malignant transformation. Now it is a problem occurs here. No dysplasia showed 25.7%. So that's more scarier than the severe dysplasia. Severe, definitely, I know because it is going to today or tomorrow, or I should be under observation. But no dysplasia showed 25.7%. So we don't know. It's not as simple as it appears to be. So these are the cases published by the Wonderwall for the oral leukoplakia for dentists. Here's even this. This is a female of 61-year-old. They did a biopsy and they found it is to be a no dysplasia. Was all good, and the patient recovered within less than 6 months. There was a recurrence of the leukoplakia. The male, this was the same by him only. The 57-year-old male came first time, saw no dysplasia. This patient was lost with the follow-up itself. So after 1 decade, he came with the squamous cell carcinoma. So it's a male or female, the recurrence and chances are always the higher side. So it is, you should, what it looks and what it describes may not be the same. What it appears is not same. Okay. This is around for the 2022 WHO book says there are 28 features of oral leukoplakia for the oral epithelial dysplasias. Now, the Hankinson, he has mentioned they are still subjective and grading is still difficult. Okay, this is that's why I given the full article quote. You can read this. Okay, if we have to go to do something else to go for the betterment of a patient, so we go for the IHC. So every time we cannot be predicting or thinking that this will be of malignant transformation. So sometimes we take a help of the IHCs. Unfortunately, the IHC, we have so many things, so many markers are there. So it can be very difficult and vast and varied. We have to just trust and go ahead. Okay. These are the few examples we have just made. On the upper hands, these are expression more is better. The lower, the lesser expression are bad. Okay. Okay. Current limitations of this. The problem occurs is the scoring system of the IHC. Should I call it as 10% of the cells, 20% of the cell? Now, how to make it as a 20%? Because it also depends upon the tissue which you have sent to me. Okay, what I have received might not show any dysplastic features. Might be a second sample which you have sent to somebody else might show a dysplasia for that. Okay, so submission, that's why I requested if you're submitting, submit the whole thing to one oral pathologist. Okay. Now, this is a very, very interesting. I think this is what we all need to answer for that. Is the oral cancer, oral leukoplakia is predictable? Answer, I don't know. But I have a question for you. If you answer for that question, I also have an answer for this. Any clue of the question? Okay, if you predict this, I can also predict that. Okay, so it is a bit difficult establishing the exact malignant transformation, which patient will go for malignant and which will not is still a challenging one. There are few factors which are says that these are the factors we have to look for and be careful so that the patient should be under the observation. The few factors are, one is non-homogeneous are more chances of getting into a risk for that. Second, advancing age are also at the risk. And third, the gender. Females are more common for the malignant transformation. Although the other study by Yang said there was no difference in their study. And the next one is site. They say retromolar is more common with the malignant transformation, and size does matter, always do, more than 2 centimeters or that, but even the smaller may also transfer, we don't know. The color also matters. pink, gray, and red granular appearances are more tend to be increased associated with the dysplasias. This is quite, I don't know, I'm not saying anything to blame on the surgeon or something, because it is mentioned that for CA, you need to cut 1 centimeters from the border. So there is no such guidelines for the oral leukoplakia, how much far he has to go for that. Okay, so maybe an inadequate surgical margins also can be a risk factor for the malignant transformation. There's this is the next one. The very common is there is major transformations happening for the malignant transformations may not be same at all. It is not, it's geographically, and every studies have a different what is this percentage which go for the malignant transformation. Now in America, the Native Americans, they will remain into the benign and they will never go for the malignant. This I have taken from the textbook of Rexy and Scuba. Can read that. That's, he has mentioned the same line. And in the study done by the Australia, what he says is, out of 202, only 3 went for the malignant transformation, means it is around 1%, 1.5%. Okay. So the different malignant transformations varies in the geographic. That may be because of the habit, then the social habits, then also the kind of the visit to the dentist or for the physician. Okay, all these things varies a lot of things. So what they say is the patient who had a recurrence of the leukoplakia has higher chance of going for the malignance than with the non-recurrent lesions. Okay. This is from the recent textbook of the S.R. Prabhu textbook. I just taken this few things which can be used for the management of the oral leukoplakia. This is the of them. The most common one we do is a surgical excision. We always think that that's the main one which we do, remove the lesion and then forget it. That should be the how we always think for that. That's not the case. That's a surgical removal is the major treatment what we do for the patient for that, and that is the usual choice of the treatment also. But that does not mean that it will not come back, or it will that lesion is being completely off. It might come back, recur, or it might also come back as a CA also. So surgical treatment. Now I do a surgical treatment, means I just want to remove it. Now how safe is the patient after that? The recurrence is being done by the conventional scalpel have a 49% of the recurrences. Now, rather than taking it as a negative 49% recur, should also consider 51 doesn't recur. That's also a positive way of thinking for that. The best they consider is the carbon dioxide and the vaporization, where only about 11% of them recurred for in that which is the most common site. In India, buccal mucosa is the most common site for the going for the malignant transformations. Okay, here for the recurrence they have mentioned. The recurrences is on the retromolar pad. If it is the 57% of the patients reported with the recurrence of that. And if it is a multiple one, it is on the buccal mucosa, retromolar, or on the floor of the tongue, anywhere it is of the, there is high chances of recurrences of 43%. The least one was the 30%. 13 on the floor of the mouth. Okay, and these are the few factors. Okay, let's go. Unfortunately, till today, we do not have anything which like the chitty, where we can do multiple things at once. Maybe we don't have anything which stop it, which we don't have anything which can reverse it. We don't have anything which I can delay it. Only thing is I can prevent the becoming into malignant transformation, or the lives can be added only if the patient is under good follow-up and detected earlier. That's how we can help them. This is a quote given by, before the presentation, I called him. He gave me 3 beautiful suggestions. I have just added up for that. Okay, if oncosurgeons add days to the life, okay, early detection by the dental surgeons add lives to the days. Okay, okay, follow. there are treatment options are again two, other than the treatment of the six what has been listed. One, some patients may not willing to go for excision because it's asymptomatic until unless it is a symptom. The patient may say that it's all good. Then we need to follow for them. Those who are willing to do we have done with the excisional. But what they say, if your patient is not willing to go ahead with the excisional of the lesion, then we need to follow. But how long? And it's lifetime. It's the lifetime follow-up, and how often you want to follow. This has been recommended for at around 3 months to 12 months interval, depending upon the OED, oral epithelial dysplasia, how you graded him. So mild, moderate, or severe. Any of them can become Dashavatam later. We don't know, but still they consider it's a 3 to 12 months period you need to follow for lifetime. Okay, so this is still it's a questionable how efficient is that. Now this also has been given, the case has been given from the Raju sir from Bombay Nair Hospital. This is a new menace. This is the what we have to look for our young generation, especially our own students, because this doesn't smell like a tobacco, and it doesn't like the same how a smoke can come in. It will be the odor will be for a longer time, and anybody can recognize that he had a cigarette. Now this is unfortunately comes in a lot of flavors, and it has been marketed in such a way. There are lots of myths and facts about this, but this is equally now a concern for us. I think we need to first our own dental students, we need to speak about this, and this one can be a separate webinar, how and what it can be for the vaping. And we should take care of our own dental students, because it doesn't look, and it's easy to carry. I have seen the vaping as small as pen drive, less than 2 inches. Okay, thank you, sir. Okay, this is I asked him, what is the take-home message I have to give? He sent these many take-home messages. For that, any matter, any color, it's not in the coral pink or not pigmented one, anything is bad. Need to go for a histopathological evaluation. So, red is danger than the white, and white or red, not all will become into cancerous, but it is not showing cancer now, does not mean that it will not be in future. So, you should be under observation, need to cut for that. Okay, then repeat biopsy if if you are not happy with your histopathology. The last one is very interesting for all the clinicians. That's his line, not mine. Do not get offended or angry if the diagnosis does not suit you. Okay, I had added the last line. Okay, please send the complete tissue so that we can help you better. Okay, then how we can. Now we have understood it is going to recur, or which lesion is going to become into carcinoma, which is a higher chances for the malignant transformation, is unpredictable, and it cannot be do with any of the as now available technology. Cannot say that this will go and that will not go. Okay, so avoid. And the cessation of all forms of the tobacco, including our own students and the patients, every session that in the OPD, we need to do a cessation of tobacco habits. Okay. And this is Raju sir, last line he has sent. This is behind every successful oral pathologist, there are many dental surgeons, especially the oral surgeons, students, and very importantly, the patients. Okay. This is our last year 2023 IOPS symposium. Okay, anybody willing to come can contact Chaitanya sir or Vanki sir, and we conduct a program. We'll give an opportunity to talk to the university, but this is offline. Our university wants it to be offline, and they want you to come here and talk to our student and share your experience. Okay, this was 23, and this is last year. Very successful. We had first we had a lot of over 200 plus delegates we had. So anybody interested, please do contact Vanki sir or Chaitanya sir. They will arrange and they will contact with us. Then we'll take care of that from there onwards. All are welcome, and welcome to SeGi Okay, and that I would like to thank you. This was given by Subra sir. He has given it to Rajiv sir, and definitely it is just transferred to me later on for that. Thank you for your undivided attention, and thank you. Hope I met with your expectations and what you had. I am not or something. That's why I assured and promised I will not discuss something on the histopathology, which you all are much more learned better from Prof. Maya. She has taught you all. So there is no point in the discussing. So something new you learned today. If you learned something, I'm very happy for that. Okay, I would like to thank Prof. Maya. Thank you very much for this opportunity and her teammates for this. I also like to thank the Dean, Prof. Baby John. Thank you, sir. Thank you very much. Thanks for your opportunity. And also Dr. Rajiv Kumar, then the management of the Vinayak Mission for the opportunity for this. Hope to see you all offline once in the Vinayak Mission soon. Okay. Thank you.
Thank you, Dr. Anand. It was a wonderful presentation.
Thank you. Thank you very much.
And I could see Rajiv Desai sir in all the slides. I always see sir's presentation, and I could see sir here. Thank you, Rajiv sir, if you are here.
Thanks
and,
for sir.
Vidya, take over.
Okay, yeah.
Participants, if you'd like to know about anything, you can post your questions on the chat box.
Any more questions? You can just put it to Prof. Maya. She'll give it to me later. I can do it. Shouldn't be a problem. Okay. Hope you all enjoyed the session, and thank you very much. And I'd like to thank our my teachers, Vanki sir. Thank you very much, and Rajiv sir. Thank you very much. Because of you all, I'm here. That's thank you.
Thank you, Dr. Anand.
Thanks. Bye bye.
Thank you, sir,
Thank
for that
you.
incredibly insightful and engaging lecture. We are truly grateful for your time and expertise. To acknowledge your valuable contribution, we would like to present you with a certificate of appreciation.
You can stop sharing.
Yeah. Oh, 1 minute. Stop share. Okay. Thank you. Oh, thank you. Thank you very much. That's nice. Okay. Okay. I think we can. Any questions?
The certificate will be sent to you by mail. Yeah.
Yeah. Thank you. Very kind of you. Bye bye.
Thank you. Bye bye.
Now, I request Dr. Ambika Ma'am, Associate Professor, Department of Oral Pathology, to introduce the second guest speaker for the day.
Thank you, Dr. Vidya. Good morning, distinguished guests, colleagues, and respected participants. It is with great honor and privilege I introduce to you an extraordinary scholar, researcher, and educator, Dr. Sivan Padmapriya ma'am. Madam's illustrious academic journey began in Tamil Nadu, India, where she earned her bachelor's degree in dentistry and a master's degree in oral pathology from Tamil Nadu Dr. MGR University. She then pursued her doctorate from the prestigious Department of Microbiology and Parasitology at UPM, Malaysia, specializing in the groundbreaking field of dental stem cell therapy for viral infection. With an impressive 25 years of experience, Madam has been in academic, research, and clinical practice, seamlessly bridging the world of medical and dental sciences. Her expertise spans a remarkable array of disciplines, including pathology, virology, microbiology, stem cell research, cell biology, molecular biology, bioinformatics, and regenerative medicine, to name just a few. This multidisciplinary approach has not only enriched her own work, but has also impact on the fields she served. Ma'am is an innovative educator known for her mastery of modern teaching methodologies and her dedication to academic excellence. With over 31 publications to her credit, an H-index of 8, and more than 260 citations, her research contributions continue to inspire and guide professionals globally. Ma'am is proudly associated with several esteemed professional bodies, underscoring her dedication to continuous growth and contribution within her field. Today, We are fortunate to hear from a visionary whose dedication and insights have shaped the future of medical and dental science. Please join me in giving a warm welcome to the distinguished Dr. Sivan Padmapriya ma'am. We welcome you, ma'am.
Now, I would like to request Dr. Sivan Padmapriya ma'am to start with the session on stem cells for infections. I request the participants to pose their questions in the chat box.
Is it fine? I can share. Is it visible, my presentation?
Yeah, we can see, Doctor. Yeah, welcome.
Thank you. Thank you so much. Thank you for the wonderful introduction. Maybe I don't fit much. Thank you so much. Today's presentation is about stem cell therapy for infection. That is my PhD work. In fact, till now, I'm just sticking on to it because it's really wonderful. Near future, you will have an something different view. I'm sure the stem cells will go up. This presentation will be very simple, like from basics and little bit of my work, but that also you can understand very well. So stay tuned, okay? I belong to RAK Medical and Health Sciences University, in which we have the RAK College of Dental Sciences. Small introduction related to that. Let me go. First, I would like to thank Vinayaka Mission and the PFA. It is really, I am more privileged to attend the 25th year celebration. I feel more happy for it. And I thank the Dean, Professor John, and Dr. Maya for bringing me here. Thank you so much. This is our college, that is university, and we have medical, nursing, pharmaceutical, and dental. Our unit is little away, that is the last one, the side picture. And we work under our Highness, and he has given us a nice, the essential freedom to work very well here. This is our college. Our clinics are well standard. I mean, very well standardized with, we have JCA accreditation for a long time, in fact. Recently, last year, we got Diamond Standard. In fact, last month, we got the Australian Dental Council accreditation also. So last 1 year, we were just working like anything. It was really very nice to work with the team. And I wish all of us, I mean, from even in India, many colleges should start doing this so that our students, wherever they go, are proudly, even in India to serve, we will serve with the maximum standard. Recently, we started even metaverse. So we had training. It's really interesting because we are moving ahead. So we have to move towards, in Tamil, there is a saying, Aadi karakramata, Aadi karakano. It says that if you want to take milk from the cow which dances, you have to dance. Like that, for the recent people, we need to change ourselves, update ourselves. In fact, as teacher, I feel we need to change a lot. Our college is very beautiful. In the building, 7 floors are there and given for everyone. Coming to RAK, Ras Al Khaimah, we have the longest zip line. Beautiful mountains. I have been to Himalayas for Kailash travel, and I feel no difference there and here when I look into the mountains. And it's really very beautiful, beautiful natural beaches are here actually. In UAE, most of the beaches were like man-made, created, and it's very beautiful, of course. But this one is so natural and very beautiful. Like weekends, I just wait to get inside, sink myself. Really a beautiful place. In fact, I was growing almost 50 to 60 crops, different crops back my garden. And I'm almost taking most of my greens and in fact, Murungaka, lots of from my backyard. It's a nice place. Lovely beaches. You just cannot come out. Coming to the presentation, the main outline is let us recall what are all the stem cells, what is infection, and what is repair and regeneration, a simple explanation. And my highlight will be what I have done a preclinical study. It's a magnificent work. And now I feel, after coming out, I feel that how much I have done for it. And what is the current trend in stem cell treatment, especially related to stem cells, infections. Infection after the COVID, it has become a very big talk of the town. The treatment modes related to stem cells. I just wanted to start with maybe a negative opinion, but it is true. We have to accept. We know everything. Almost the science says technology has improved, and we have gone. Now the quantum theories and then the string theory. Too many things, dimensions of more than 3, so many things we are talking. But I want all the pathologists to hear me that, is it possible? What is there in single cell, even in the outside cell membrane? Can we confirm that we have confirmed all the layers, all the proteins? I don't think the answer will be yes. We know the landscape of Mars, but not the cellscape of our own body, single cell. Added to that, what the function it is performing at a given moment, maybe just half a second or millisecond, at the same time, what is happening in every situation, I don't think we have anything to talk about. We are more outward than inward, that we have to turn inward. Otherwise, the stem cells we cannot bring to a better one. Coming to the collecting the basics, stem cells. What are stem cells? If your hair and nail grows, and if your skin renews, you have lots of stem cells. So we all have stem cells. It is not just in the lab. They are self-renewable and they can be available to restructure. The most important is functional tissue. That's the one. That means we cure ourselves, self-curing, right? So we are curing because of the availability of the stem cells. The stem cells are available all over the body in different locations. Those areas, what cells are in need, and they will differentiate. But we all came from one cell. Just one cell, half from mother and half from father. And they have all the informations. So we are still very, very, very primitive stage as far as the DNA is concerned. 100% DNA, if we take, we know only 2 to 3% is for this body. Remaining 97%, can we say nonsense? No, we are nonsense if we say that. Because that 97 controls the 2. One more I would like to add. More than 55% of the remaining 97% of our gene, human gene, is linked with virus. So let us move. So the different stem cells we have. So what is the potency? Can we use them? Yes, we can use them. There are different, their ability to turn into different structures are different. So according to the potency, they say totipotent, pluripotent, multipotent, unipotent. It means like it can turn into anything, embryonic stem cells. In fact, embryonic stem cells are not accepted in many places. Now it is modified, the things are getting better. But again, I would like to say people know 100% about stem cells only can touch even the unipotent stem cells. It's better to restrict the embryonic. Recent ones induced pluripotency. It means any these pluripotent, multipotent, unipotent cells, the unipotent cells also can be induced in the lab to become any cells. For example, When I take the dental pulp, it has lots of stem cells. In that stem cells, if I take the mass and then as the dental pulp stem cells, but I induce them to become insulin producing beta cells, I can. So you induce them to become, they can become anything. So the adult sources, mainly the dental pulp stem cells, will become talk of the whole world near soon, because even the exfoliating cells and then medically wasted the third molars and premolars for orthodontic should be preserved for the future. Autograft, which is the one which I really appreciate and accept it, that is same person using their own cell. For example, if I have third molar, I am removing, then I am storing it, and I have my dental stem cells. If I need anything for the future, maybe just an aging process, and I want something from them, and I can take my own cells, retrieve, and then propagate, and then what I want, I can make it. So it's autograft. It is same cells used for the same. Family related, I think most of you know, but I vote for autograft. This is not my aim. So coming to again the timeline, first it was introduced by 1902, but from that time it was the word hematopoietic progenitor cells. From that time, 1991 here, if you see the Professor Kaplan, he has introduced saying the word mesenchymal stem cells. After that, it has reached tremendous work. If we collect, we can do it with AI. If we collect information from AI, maybe recently stem cell related works were magnificent. So near future, whoever is here, dental students or whoever the oral pathology students, believe me, near future related to oral pathology and AI, you will have stem cells related, you'll have more work. So we are here, but our work was something different. So current what are all infections? Let us go very fast because you know very well. Virus, bacteria, parasites, okay? We call them it is better to divide into intracellular and extracellular. Intracellular, the viruses are more, some of the bacteria and of course the parasites like malaria. But why the intracellular? Is because when it is intracellular, when they are inside the cell, we need to kill the cell to relieve the infection, right? So is it possible to kill all the cells? It's not. So if we want to preserve, we want to remove only the problem, not the cell as such. Extracellular antibiotic can take care. But is it that, antimicrobial resistance and so many other things are coming up that we are in need of newer one? This is about COVID, how it affected the different organs. This is a nice presentation for multiple organ involvement during severe infection. It can be just for COVID you can take, but it is almost applicable for all the infections, especially if they are in the intracellular areas, because they hack the epithelium, the cell membrane, then they go inside and they stay inside by hacking all the systems. It means they are really, they know how to intrude our cell. They know better our cellscape. That's what I would like to say. The virus and the intracellular pathogens, they know better than what we know. So they go inside and they stay inside. They harm almost all the body's structures. And this I want you to remember till the end. Whenever there is an infection, even if it is just an abscess, dental abscess, it is not that only that area you will get the heat. I'm just saying the thermal changes. The fever will be there in the whole body. It means the cytokines which are locally working and released are actually going all over the body. So again, you think all this infections related, if it is just respiratory, just GIT or just some epithelium, something, no, it is not just. They are actually going to the whole body because every 5 minutes, our full body circulation goes around and comes back to the heart, including these cytokines. So these cytokine storm, which are coming into play, is actually the main culprit. So they say they found that even the stem cells treatment can control the cytokine presentation. There is always pro-inflammatory and anti-inflammatory. Regarding this, the informations are actually limited, I feel. I'll tell you there is an infection, then there is a secondary infection. The secondary infection would start with pro-inflammatory. The previous infection is already with the anti-inflammatory. They will mismatch. There is always a problem. So secondary infection is one of the biggest issues any hospital-induced infections. So near future, they will search for it and they will come to the dental stem cells. What are all the current treatments? I think antiviral, antibiotic, antiparasitic, supplemental. I think nothing more than this. And they are all struggling, especially in COVID time, they were all struggling and we saw a very bad the death rate. Antimicrobial resistance, antiviral or anticellular. Actually, they are going inside and they are killing the cell as such. Not all the medicines are relieving only the virus. So vaccines, are we sure? And how many vaccines we will take? So just let us think of something alternative. Coming to what is repair and regeneration? Any cell injury, it is not just for the infection alone. This is included for all cell injury. Any cell injury can be physical, chemical, infectious, and genetics. That is making the cell injury. It can be reversible or reversible. Irreversible, we know they come back to functional tissue because it has stem cells. The local stem cells works. And there is angiogenesis, blood vessel formation, necessary nutrition and growth factors are given. And especially in the young people, the healing is better because they have better stem cells. See, we are all with the stem cells. We are all renewing with stem cells. But how to take the idea is when there is an irreversible injury, how to bring them to functional tissue is the clue here. What we wanted to do is by providing the essential stem cells, nutrition, growth factors, and allowing them to go for angiogenesis, you cut the non-functional tissue, come back to the functional tissue. That is the aim of stem cell therapy. And if it is infection, then it is infection related. So stem cells for infection, people have tried a long back. It is not a new one. So they were started talking almost 2000, 2004. By 2000, only Granthos, he was identified the dental pulp stem cells. But before that also people were talking about, especially related to mycobacterium and then sepsis related. And these are all the things were discussed for long. And how it works, stem cell, how it works. They say homing. When we inject, then it goes to the area because they have the cell membrane proteins that where they belong to. They say that they have a memory and they go there and work. Okay, this is reported and found with the research, but more research are in need with my experience. And then they aid the self-repair of the cell, secreting biomolecules which can help the nearby, like a paracrine, And they say that it's not that they are just only helping their own cells. They are actually making the angiogenesis, bringing their all growth factors and everything, signaling molecules. So they make their local work. They are like self-start. So they have anti-inflammatory, anti-apoptotic, anti-fibrotic ability, immunomodulatory, antimicrobial, antiviral ability, as well as they say, few reported that direct transmission of mitochondria. In fact, if you remember, the mitochondria to the human cell came as an introduction inside, right? So maybe we can accept it, but we need to prove, right? So how to prove? And they pro-proliferative and pro-angiogenetic. So how to prove? These are all the properties they have given, but it will be more scientific if I start talking about. So let us just go to the next one. Previously, they were giving the first started with cell therapy. In fact, we gave cell therapy. It was 2016 started, 2018 completed my work. Then they thought, we don't have to give the cell because it has DNA. How to introduce another DNA? Yeah, we don't want to. Then they took only the conditioned media because they said the conditioned media is actually loaded with these type of the paracrine function we need from the cell is there. So the cytokines and whatever the magic molecules are there. Then they came again, the conditioning media is actually what we give them to grow. So it is added with some other material. Maybe there is an immune rejection or some problem inside the body. So they what they thought, we will just remove only the magic particles, the vesicles, or the one which is secreted by or given by the stem cells. So they started removing. Those are the microvesicles and exosomes. Exosomes are very small. So nowadays it is the final end now is actually the exosomes. Exosomes related studies has been started, and you can see microvesicles and exosomes related to this. We can talk even 1 hour. So I'll just go through because those who are interested can go and read more. This is our research work published in Frontiers. And I'm just showing it to you that the amount of work we have done. This is animal study, around 72 mice, and we have done almost all liver. In fact, we did blood vessels also. The paper is yet to be presented, and full for the liver, because it's dengue infection is the model for us. We did even before COVID. Our supervisor is like, we say Dirkadarsi, he has done it well before, but since dengue was the more commonest in the Malaysia, we did model was a dengue infection, and we gave stem cell treatment, hematopoietic stem cells, endothelial progenitor stem cells, as well as dental pulp stem cells. These are all my supervisors. I thank them for giving me an excellent opportunity and completely working with me with lots of grand material and everything. I thank them forever. And Professor Suresh is actually in Vice Chancellor in Savita Dental College now. This is the model for our study hypothesis, which they told you that our own stem cell, if somebody is maintaining, keeping it, if they go to some infection, more place, and then they get the infection, because some of them are just in the location. And instead of suffering with severe dengue, they actually take their own cells treatment so that they will go with the without any problem. Is it possible? Let us see with our results. In fact, any research has to go through lots of work. We need to isolate, we need to find out what they are. These are all the things we did. Whether they are really stem cells, are they expressing flow cytometry, we have to do, find out whether they are the same cells, and then grow them and find out whether they are transforming all these things, and then whether they are compatible, then give it to the preclinical, the study with the animal, and then find their result, and later it comes to the clinical trials. It is still in the clinical trials. It is yet to come with the different one. This is a study model which I have made. I wish more similar studies can be done in India also. I'm very happy to help you people because, it is here. I have to transfer. Fine. So very big study. I think planning itself took too much time for us. So this just I go through the study. Clinical, when we find them, even in the clinically, you can see the last one, the picture here, the animals are behaving like the one which is not infected. This is infected and not treated. But the infected and treated is behaving almost similar like. Now I want you to see only, because all of you will get, except PG students and the professors, it will be difficult for you, but I'll just tell you the green and the first one blue, okay? The second one red is actually the infected, not treated. You can see all the greens. This made me to think a lot because it's excellent. In fact, even more. Biochemical presentations, again, it was, all the liver damage releasing the biomarkers, AST and ALT were really less in the people. Is histopathology, unless otherwise we see histopathologists will never accept. Imagine this is same magnification, liver, central vein, and you see the same picture and same thing, we are automated machine for the staining. So it is same time staining, same type of staining, nothing changed. You can see how much the infection have made the dilatation and the redness, because it's hemorrhagic fever, right? And whatever you have is the infected here and it is treated. Until the 10th day, there were damages, but after that it started correcting. So it is that the infection is progressing, but it's not progressing to the damage. We measured the hepatocyte size and the Kupffer cells, number of cells and size of the sinusoids and everything with the software image analysis. And we found that they were very much close to the normal. Apoptotic cell count was really very high due with the infection without treatment. Infection with treatment, you can see how much it is reduced. We have proved that it is definitely reducing the viral infection-related apoptosis. It is transmission electron microscopic view. In fact, I just colored them with my different software. And you can see even the Kupffer cells and everything. It is little difficult, but what I'm saying is we did all the studies. Immunohistochemistry. Again, the one which is with the treatment here and here, the with the treatment, there was not even, initially there was the color what you see with the fluorescent green is the infected one, but it is nothing was visible. And we didn't complete, we did next generation sequencing. So we did how many genes are upregulated, how many genes are downregulated comparatively. In that we found around 59 genes significantly upregulated, but it is normalized in the stem cell treated one. Again, we were not, what to say, our supervisor was not ready to stop with that. So downregulated, we were having 51 and 30 were normalized. It was only 21 days we continued. Cell cycle related genes, what it happens, and apoptosis related genes, what it happens. So we did. Again, we found that the most of them are normalized in stem cell treatment one. So the animals were living normal, clinically bleeding was insignificant, all the platelet count and everything normal, microscopic, everything, almost whatever we have done we were really surprised. And that made me to think that these stem cells are very, very good. We have to be very careful. We have to be very careful in using. So just I'm giving the same slide that we have almost proved almost all of them. Stem cell therapy is good. So it's a holistic treatment unless we do a perfect care. Okay. It will definitely, it is not just improving the liver. It was also working for major blood vessels. The paper had to be published, and each and every important, the cytokines also we wanted to look in. We're still working on it. And then they have the ability to regenerate, not just the liver. It will not, as I told you before, how the cytokines can travel everywhere. This paracrine action from them also can travel everywhere. In fact, there was a recent study saying that even the pregnant female will be healed by the child inside the womb, it seems, because they send material to the mother to heal herself. So it will go everywhere. This we should keep in mind whenever we are touching the stem cells. So coming to the ethics, in fact, I'm just talking about more good about. So maybe you will think that, is it good? Is that have no disadvantages? Lot. Unless otherwise the people worked, this standardization should come. Have worked, and then they are mainly from the basic stem cell biology. Any other people should not allowed to work in. This is my request, to work in stem cells. I'll tell you one example. I'm from Tamil Nadu. I cook sambar very well. If I cook sambar, somebody comes inside my house, they'll say, this I heard every time. It means I know I cook very well and they taste it very well. But that is because I'm cooking for so many years. Can I say that I can make sushi? Or a great chef from Japan who makes excellent sushi can say that, yeah, I can make sambar? No, doesn't look nice, right? Same like that. That is because 50, 60, 100 research you have done, if it is not in stem cells. Don't put yourself that you are an expert. I'm not saying you are not supposed to do. Kindly keep people, those who have worked or working or have very good knowledge about stem cells in the lab basics to do. Otherwise, whatever the risks and the problems, what I'm going to talk will be the talk of the town near soon. So there is possibility of harm. Even the necrosis can happen, immune rejection can happen, even during in the culture, and you may not get what you wanted. Contamination is the biggest problem. We lost so much of cells sometimes during the work. In fact, I wanted to see, that was my original project. I want to see enamel. I want to remove my first paper in Nature Publishing Group is related to odontogenic epithelial stem cells. We wanted to see the enamel, and because of contaminations, we couldn't able to proceed. And there is a variability, its ability to reproduce. We call them passage. One set when we propagate, and then the second set, third set, we call them first passage, second, like that. The function of the first will not be same in sixth. So if you are giving it for anything, you cannot expect the same thing in a different one. Cells are different, they behave different. They are to be treated as the baby which is not yet born. Please, I repeat, the stem cells to be treated as babies which are not yet born. They have to be taken very, very, very care. If it does not happen, then it can be a lab-induced problem. After that, patient receiving and then standardized, so many things are there. If anyone asks me immediately to start stem cell treatment, I will be the first one opposing. There are different clinical translation pipelines are going on. It's a good example from this paper, but except for blood dyscrasias, which was started long back, that was the first hematopoietic stem cells given, everything is in the clinical trial level, but clinical trials are going on in exponential way. This I wanted to tell you that, the viruses are keep on coming. Even now the mpox added. So many things there. So we need to find something different. So I'll go through few slides. It is just to tell you that how many reported and ongoing clinical trials on. You can just see that you may not be able to read. It's okay if you want. You can very well easily get from online. If you want, I can send it to you. I have full package with me related to stem cells. Anybody interested in working, writing paper, I'm very happy to be with you. And some more, it never end. These are all for the COVID. And some more. Many got very good results, actually. Treated, it's more going. This is with the exosomes. So now you can see how much the improvement have come with the clinical trials and everything. I wish similar technology, similar research proposals, similar plans completely. I've done my clinical trials in University of Washington. So I think clinical trial also needs some extra studies like stem cells. So I know how difficult or how well we have to plan. The same thing to be conducted in different places all over the world so that it will be more transparent. Because every researcher, 90% they have that their research too should come out very good. They might do some mistake. It should be transparent. That idea should not be there for any researcher. Maybe you have lots of questions, but if it is a similar question, maybe I'll answer you now. May I use your stem cell? Yes. Won't stem? Yes, you can use. But if you want in time, you have to already preserved. and propagated and kept freezed, cryopreserved, so that you can take them and use. Okay. Is it infection possible? It is possible because we already have more than 50% of viral genes. Why not the other one? But they say that they are in a very immature stage, the stem cells. Their surface proteins are not much, and the cells, the viruses or anything which is supposed to go inside may not be possible. Studies are going on. We have to clarify this. And it is reported there are certain things. Then is it that the whole only cells will be inside? They say that not even 0.01% of stem cells actually staying back. How much we need? A lot. Is it possible we can manufacture? It is possible. Near future, because of technology, we are going to have everything perfect. These are all the challenges which actually talked with the related to treatment failure, loss of stemness, back the infections again, immune rejection, whether they are really what we are sending is the real stem cells or not, what the material which is there is really working or not. So there are more challenges. Again, this paper has discussed it very well. This is the recent paper we published about the role of adipose-derived stem cells. In this, only one novel idea I would like to say as an oral pathologist, oral and maxillofacial. We found that head and neck region, the formation is mainly, the development is mainly from neural crest cells, almost all the structures. They say that even the adipose tissue which are distributed, them are showing different markers. So if that is the case, if there is any liposuction or anything, please preserve the adipose-derived stem cells because they are also very good for working with the, especially neurology-related works. So that's my last. In front of the cell, as I go more near, as an oral pathologist, I feel that you are very small, oh my cell, by size, but yet wisely. By actions, actually, I feel I'm more, but I'm a trace. For yours, surpass my needs. And these are all the universities, University of Washington, University of Iceland, Oslo. These are all the places I worked or studied UPM. Now, currently, I'm in records, happily here. And these are all my friends here. Thank you so much for your help. And this is a greatest privilege for me to come and talk in front of you. Questions, please.
That was a wonderful session, Dr. Sivan Padmapriya. And
Thank you.
I could see our alumnus, Dr. Sunil's name also in your PPT, in your presentations.
Yes.
And
the last paper was with him. He did second PhD in adipose stem cells.
Yes, I know. He had given the oration recently in the last conference in Kodai. And yeah, he's my senior and friend. He keeps coming here as PhD examiner. It was a wonderful presentation. And it's tough to understand everything about stem cells. And those who have any doubts, they will contact you. You have given your email ID and in the presentation.
Perfect.
Yeah. Thank you very much.
Thank you.
Thank you so much, ma'am, for sharing your knowledge. Your insights and expertise made a significant impact, and we are grateful for your valuable contribution. We would like to present you an e-certificate of appreciation.
So nice of you. It's okay. I saw that when you were sharing before.
I'll be sending it to you by email.
Yes. Thank you. Nice, very nice. So the questions will be only through mail. I will answer, correct?
Yes. If something is there, yes, we can ask now only.
No questions.
They are well versed. Nice.
Your presentation was so much information was there, no? So if they have to think and then write only.
So I started from basic, that is why.
Yes.
Hopefully, it was satisfying for all the people, like the postgraduates as well as for the undergraduates.
Yes, there are so many faculty also who have joined, so many fellows have joined. I'm so happy to see huge participation from the interns, postgraduate students, faculty of IAOMP, and fellows of PFA.
I wish to add one more. I am a PFA Merit Award receiver 1994.
Oh, that's great. Yeah, great to know that you were also. Yeah.
1994 I received, and I wish that those who are watching here will receive more, because I did one presentation, one international presentation, one national presentation during my BDS program. I did one work with Dr. Gnanasundaram, oral tobacco and mouth changes, and then another one was perio, one case presentation. So all these things were added, like what is my progress and everything. They gave me that award. From first year to final year, I think I was 2 times or 3 times topper.
I remember your name from Dr. Samrat's mouth.
Exactly. Dr. Samrat's time, that was the time I received in Coimbatore. The meeting was conducted. Yes. In fact, I wanted to do more with the PFA. Since I moved it here, once my husband came, I couldn't do it. Hope I will do more after I come here.
So you were the best person for an association, that is Vmsdc in association with PFA. You are the best person for a lecture in this platform.
Thank you. Yeah, I'm very happy for it. And then it is 25th year.
Yes, 25th year of Vinayaka.
Great celebration.
Yeah, thank you.
Thank you so much.
Yeah, over to Indra.
As we come to the end of this event, it's now time to express our sincere gratitude. To do so, I would like to invite Dr. Indra Priyadarshini Ma'am, Associate Professor, to deliver the vote of thanks.
Thank you. So, wonderful afternoon to all. On behalf of Department of Oral Pathology and Microbiology, Vinayaga Mission Shankaracharya Dental College, I extend my gratitude to you who all made this today's continuing dental education program grand success. I would like to thank the management of VMRF DU conducting a series of programs for the year of 25th celebration. And first and foremost, I express my sincere thanks to our esteemed speaker, Dr. Anand Sir and Dr. Sivan Padmapriya Ma'am for sharing their valuable insights in oral leukoplakia, the new concepts and stem cells, and then all the research work respectively. Ma'am, you have done, and sir, expertise has truly enriched our knowledge, broadened our understanding. Thank you so much, sir and ma'am, for the wonderful session. A special thanks to Dr. Rajiv Kumar sir, Chairman, PFA, and Dr. Maya Ramesh ma'am, Secretary and PFA Indian section, for the guidance and support in making this collaboration possible. Very special thanks to Vanaki sir, IOMP President, and other office bearers of IOMP and EC members. And also I would like to thank the PFA fellows and Senate members. I extend my gratitude to Dr. Baby Jan sir, Dean of Vmsdc, and Dr. Maya Ramesh ma'am, Professor and HOD, for the leadership and encouragement organizing this event. Your unwavering support has been instrumental and its great success. A big thank to organizing team and the technical support and administrative officer for the efforts in ensuring the smooth execution of the online session. Your dedication behind the scenes is truly commendable. And but not the least, I would like to sincere thanks to all the participants who have actively engaged till now, and your enthusiasm, your presence and interaction made this session meaningful and impactful. And all the faculty members from the other colleges and Vmsdc, UG and PG and interns, and more than we have 350 participants from overall India. We hope this program has been insights and beneficial, and we look forward to more such a knowledge sharing opportunity in future. Thank you so much. Thank you once again.
Thank you all for your active participation and making this event such a success. We hope you found this lecture informative and engaging. Thank you all once again and have a great day.
The feedback link is posted. You please give the feedback so that you will be getting the e-certificate also. All the participants, please give your feedback. Thank you all. Please give your feedback and receive your e-certificates. Thank you all. Bye-bye.
Feedback program,